Step 1. Unplug the HDMI cable from the back of your monitor or TV. Step 2. See on the capture card where it says HDMI input. That's going to be the input that will be plugging in that HDMI cable that we just unplugged from the monitor or TV. Plug that in now. Step 3. Take a new second HDMI cable and plug that into the HDMI output slot. Step 4. Take the other end of that HDMI cable and plug it into your monitor or TV. Step 5.
It would be easier for you to place it inside this.
Easier for me. Again, if you crimp the mitris valve, it will be easier for you to place it into a small incision. And then it is easier now to place it into the annulus, especially if you have a small annulus, it would be easier. Now, when we compared the magna and the mitris, problem with magna is that you have to remove the 3 sutures at the strut, but with mitris you just need to remove 1 portion. So it would be more easier, and it would give you a faster procedure. And this is the valve. When we compared magna is with mitris, we noted that the mean gradient is slower, the peak gradient is lower, and the EOA is bigger as compared to the magna is. Now, with just a 2-finger breath incision, even with a big patient, you can do minimal invasive cardiac surgery. Now, what is the future of cardiac surgery in the Philippines? Not only in the Philippines, but in Southeast Asia. I think robotic cardiac surgery, especially for the young ones, these robotic procedures is not for us, it's for you guys. You need to give patients options. You need to give them a procedure, a safe procedure with a minimal incision. So we embarked on this. We started 2 years before, then we launched our robotic program in the Philippines. As of now, we had done 7 mitral valve repairs, 1 aortic valve replacement, 1 redo mitral valve replacement, ASDs, and we did an excision of right atrial myxoma with a mitral valve implantation in the tricuspid. We also do RIMA harvest with the robot, and also we do TCRAT after harvesting the RIMA. So I'll just give you a short view of how we do it. So this is the position again. This is from robotic Lima harvest. We have 3 ports, and this is how we place our trocars. And this is, we call him Astro Boy. Yeah, now you know what my age is. Again, so as you can see, by placing the trocars, we place in the 2nd ICS, the 4th ICS, and the 8th ICS. Then we let them meet inside. So I'm in the console, and one of my cardiac surgeons would be on table. So we implement 2 cardiac surgeons whenever we do robotic. So this is how we harvest the Lima. As you can see, with the robot, you can easily see the Lima, and injury to the Lima would be lesser as compared to minimal invasive or direct vision. It's like you're inside the body of the patient. When we compared mix with robotic assisted Lima harvest, you can see there's a very big difference. And this is the patient post-operative. We usually discharge our patient 3rd post-operative day. Now, with robotic assisted mitral valve repair, we can do much more than just neocards. With minimal invasive, our repair technique is just neocard because it's very hard to see, especially at the papillary muscle. So again, same technique. And this is how we dock our robot. Again, both surgeons. Again, the technique is the same. The only difference is that the arms of the robot are inside. With minimal invasive, you have long shafted instrument, but with robot, you have good articulation, good visualization, so that you can do much more complex repair. With this, we did a triangular resection and secondary cord transposition, and do rings. And this is how we close the left atrium. Again, technique's the same, except for the robot arms. Just to see the difference between, as you can see, we can do resection of all the mitral valve tissue and do adequate suturing with the robotic arms. So this is a foreign patient, and we did robotic AVR. So again, same principle. We just place our clamp much higher as compared to mitral. The difference with mix and AVRs, you can see with great visualization, you can remove the valve adequately. And you can even see the small calcifications that's been removed as compared to minimal invasive. The one on the left is a total endoscopic AVR, and the one on the right is a robotic AVR. So you can see how we can remove the aortic valve adequately. And this is how we place our valve inside. Incision is the same, still 4 ICS. The beauty of this robotic is that you have your arms and you can easily guide it down into the annulus. And repair would be easily, especially for your aortotomy. It's like you're suturing inside the body of the patient. This case, this is a very interesting case. This is a 80-year-old male with a myxoma in the right atrium. When we reviewed this case, we noted that the myxoma is at the tricuspid valve in the anterior leaflet. So again, same position, same trocars, same technique. As you can see, there's the myxoma on the anterior leaflet in the left side. Normally, we just snug the SVC and we don't snug the IVC anymore. Question is that why didn't we just patch this valve? When the angle was too steep, so it was very hard for us to do patching. I tried to patch it, but I usually tear off the tricuspid valve. So what we did was we just replaced it with a bioprosthetic valve. In placing a bioprosthetic valve in the tricuspid position, remember, if you are to do a mitral valve, the A should be at the top, right? But for a tricuspid position, you tend to invert it down so that the A is below. This is the reason behind is that you're trying to protect the triangle of Koch. So this is the mitral valve in the tricuspid position. And the A is pointed downwards. And this is how we close the atrium. Same. You can see with this, our gradient is low. The problem with tricuspid valve, especially in mitral position, bovine pericardium, you need to place them on warfarin for 3 months. And with just a 2-finger breath incision, this patient is so happy. Okay, so in conclusion, minimal invasive and robotic approach is a viable and safe option for cardiac surgery. Mitral valve is an excellent option for mitral valve replacement for surgeons using minimal invasive and robotic platform. I think for you young guys, I like to leave you a quote. It is not the strongest of species that survives, nor the most intelligent that survive. It is the one that is most adaptable to change. Thank you.
And the next speaker, the third speaker is from South Sulawesi, our beloved young surgeon, Dr. Jaya Rasti Kusumanegara. he will present hidden and forgotten tricuspid valve surgery, how its impact in surroundings. Dr. Jaya, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning. Selamat pagi. It's an honor to be here with a very famous surgeon, I think, from moderator and the speaker, Dr. Ivan, Dr. Natapon, Dr. Bono, Dr. Martin Martinez, and Professor Jaswan. I will present on the topic entitled Hidden and Forgotten Tricuspid Valve Surgery, how its impact on surrounding structure. Maybe I'll present in Bahasa. Slide. Bisa? Slide, please. Yang tengah ya? Bukan. Itu? Oke. Tricuspid valve disease, khususnya tricuspid regurgitation, itu sepertinya kurang dilihat oleh banyak surgeon dibandingkan katup mitral ataupun katup aorta. Makanya biasa disebut forgotten valve pada tricuspid valve. Kenapa demikian? Karena menurut beberapa klinisi bahwa dengan memperbaiki left-sided valve bisa membuat stabilisasi pada patologi dari jantung kanan. Makanya sering dilupakan. Namun recent evidence menunjukkan bahwa untreated tricuspid regurgitation dapat berujung pada gagal jantung, aritmia, bahkan kematian. Dengan imaging yang sekarang, dapat menunjukkan RV modeling, dynamic role of RV modeling, sehingga early intervention dapat dilakukan sehingga dapat mengubah prognosis daripada disease ini. Slide. Nah, apakah tricuspid regurgitasi bisa dilakukan konservatif atau dilakukan surgery? Slide. Menurut meta-analisis yang dilakukan oleh Pak Nesi menyatakan bahwa pada membandingkan antara tricuspid annuloplasty dengan konservatif terapi pada pasien tricuspid regurgitation yang dilakukan left death yang lebih rendah dibandingkan pada konservatif terapi. Slide. Begitu juga pada parameter lain seperti nomor moderate TR pada follow up berikutnya, tricuspid regurgitation progression dan grade pada tricuspid regurgitation itu menunjukkan angka yang signifikan, yang reduksi signifikan pada kelompok dari tricuspid regurgitation group. Slide. Nah ini kapan sih dilakukan intervensi pada tricuspid regurgitasi? Pada guideline ini menyarankan intervensi dilakukan pada pasien-pasien yang menjalani left-sided valvular surgery dengan severe ATR. Itu sekaligus dilakukan operasi tricuspid regurgitasi. Begitu juga pada progresif TR untuk mencegah progresivitas daripada tricuspid regurgitasi. Pada isolated tricuspid regurgitasi baik itu primer ataupun sekunder, saya kira dilakukan yang akibat neurodilatasi perlu juga dilakukan tricuspid repair tanpa adanya pulmonary hypertension atau dilated cardiomyopathy. Slide. Pada guideline dari Eropa ataupun dari Amerika menunjukkan bahwa tricuspid regurgitasi dilakukan pada pasien-pasien yang menjalani left-sided valvular surgery. Saya kira dari Amerika sedikit lebih konservatif dan pada Eropa itu lebih menampung transkatheter terapi pada pasien-pasien yang tidak bisa dilakukan repair pada tricuspid. Slide. Kapan dilakukan replacement? Saya kira kita tahu bahwa repair pada tricuspid valve itu memiliki angka mortalitas yang jauh lebih rendah dibandingkan kalau misalnya kita ganti. Namun pada kondisi tertentu harus dilakukan pergantian, misalnya pada severe leaflet destruction atau mark calcification ataupun pada yang sudah tidak bisa lagi sudah pernah dilakukan repair namun gagal. Slide. Nah ini merupakan tipe 1 daripada tricuspid regurgitation yang dihasilkan oleh karena adanya anulus dilatasi dan adanya perforasi. Dengan mengembalikan bentuk anulus ke geometri yang sebenarnya itu diyakini dapat untuk memperbaiki kooptasi kompetensi daripada valve dan mencegah recurrent daripada tricuspid dari regurgitation. Slide. Nah, cara ini bisa dilakukan dengan suture base, maksudnya dengan hanya penjahitan apulum dengan menggunakan ring anuloplasty. Pada tipe 2 tricuspid regurgitation, saya kira diakibatkan karena adanya eksesif daripada leaflet motion. Beberapa strategi yang bisa dilakukan, baik itu yang melibatkan leaflet, anulus, ataupun subaparatus pada valvula tersebut. Slide. Pada tipe 3, biasanya diakibatkan oleh restriktif daripada pergerakan dari katup tricuspid. Dapat dilakukan komersiotomi, leaflet extension, dan pada kasus 3B dapat dilakukan pemasangan ring yang undersize supaya mencapai kooptasi pada katup tricuspid. Slide. Nah, bagaimana impact-nya pada struktur-struktur sekitar daripada tricuspid? Slide. Nah, ada beberapa struktur jantung yang penting yang dekat dengan anulus yang harus kita waspadai kalau misalnya kita melakukan operasi pada tricuspid. Yaitu kalau misalnya yang dekat dengan anteroseptal commissure ada non-coronary cusp dari aortic valve, kemudian ada AV node, kemudian ada bundle of His. Kemudian yang dekat dengan posterior septal commissure itu ada coronary sinus, dan yang dekat dengan anterior posterior portion of the annulus itu ada RCA. Slide. Nah, risk of conduction disorder itu bisa terjadi pada kasus pembedahan pada katup tricuspid. Pada studi ini menyatakan bahwa kebanyakan pasien dilakukan pemasangan pacemaker pada AV block dalam 10 hari setelah surgery. Slide. Kemudian apa yang harus dilakukan? Yang tentu saja untuk mencegah tersebut harus dihindari danger zone, yaitu sekitar 1 cm diameternya sekitar apex daripada core triangle yang merupakan tempat daripada AV node berada. Slide. Nah, begitu juga dengan kedekatannya dengan RCA, antara anulus dan RCA saya kira sangat dekat, sehingga bisa mengakibatkan resiko cedera ataupun distorsi daripada jalannya RCA. Dilihat di gambar dapat kita lihat bahwa ada distorsi setelah pemasangan ring anuloplasty pada tricuspid. Bahkan ada sampai terjadi oklusi pada RCA. Slide. Nah, apa yang harus dilakukan? Ya, dengan penjahitan yang dalamnya kurang daripada 10 mm untuk mencegah cedera pada tricuspid, terutama pada bagian-bagian posterior daripada anulus, karena di situ lokasinya RCA dengan anulus itu sangat-sangat dekat. Slide. Nah, untuk minimal invasif saya kira sudah banyak dilakukan, walaupun di tempat kami saya kira masih belum dilakukan dan masih ya kira-kira masih jauh. Memberikan angka slide. Nah, pada minimal invasif, baik dengan irisan yang sangat kecil, dapat memberikan outcome perioperatif yang sangat bagus. Slide. Dari segi misalnya dari segi mortality, saya kira bisa ditekan sangat rendah, kemudian perdarahan rendah, kemudian hospital stay ditekan sangat rendah. Walaupun di sini pada penelitian ini ada peningkatan pada risiko dari CVA pada operasi minimal invasif. Slide. Nah, ini beberapa penelitian yang mencakup beberapa penelitian mengenai minimal invasif dan beberapa parameter yang diukur. Slide. Penelitian lain ini mengukur mengenai outcome daripada minimal invasif, khususnya pada pergantian katup tricuspid dan pada perbaikan katup tricuspid. Secara umum, minimal invasif memberikan angka-angka yang bagus dari segi ICU stay ataupun length of stay daripada pasien. Begitu juga dengan angka survival rate-nya itu lebih bagus. Dan dari sini membandingkan antara repair dan pergantian katup tricuspid secara minimal invasif, angka parameter baik itu ICU stay, length of stay ataupun survival rate daripada tricuspid valve repair itu jauh lebih bagus dibandingkan tricuspid valve replacement. Sebagai conclusion, saya kira sekarang tricuspid valve bukan lagi merupakan forbidden valve dengan menggunakan imaging yang bagus, strategi yang bagus, bahkan dengan recent teknologi of surgical technique, saya kira angka prognosis dari tricuspid valve dapat ditingkatkan. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih, Dr. Jaya. I would like to invite Professor Nutapong to sit in front. And the latest speaker, well-known surgeon from Southeast Asia, Dr. Dato Seri Jeffrey Jeswandilon. As we know, he is now a senior consultant in cardiothoracic surgeon and director of cardiovascular sports and fitness in Institut Jantung Negara, and many papers were published made by him. And we would like to invite Professor Dr. Dillon to present the latest updates on X mechanical heart valves. Is yours, bro.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Thank you, Dr. Evan, for the kind invitation. I'd like to take the opportunity to thank the Indonesian Society of Cardiovascular and Thoracic Surgery for this privilege to present my talk. And to Dr. Yan Sembiring, personally, the organizing committee for this invitation. So I'd like to switch gears from the previous presentation. So when we first start to deal with valve surgery, usually we deal with the mechanical valve. So a lot of the advances as shown by the previous speakers, very dynamic changes, but we go back to what we started with, mechanical valve, and I will hope to see whether there are any advances in this direction. So I'm going to talk about the Onyx valve and to share the experience what are the latest advances in this direction, both in the aortic and the mitral region. This disclosure, I have a speaking honoraria with RTVion for this presentation of this talk. Now, when we talked about valve substitutes, there are three substitutes that we look at: the mechanical valve, the tissue valve, and the latest in the block, the TAVI valve. So all these are niched by a singular specific advantage that they have. Mechanical valve, the lifetime durability, the tissue valves with no need for anticoagulation, and they're truly minimally invasive for the TAVI valves. However, that being said, when we decide to choose for the patients which valve for which patient, we have to answer these questions. The question one I would pose first to look at the aortic valve, is SAVR better than TAVR or vice versa, and in which patients they do. How about the mechanical and the tissue valves? How do we choose these prostheses for the patients? And if we do choose a mechanical valve, are they all equal, or is the Onyx valve has any superiority compared to the other mechanical valves? So it is a busy slide combining the guidelines of the European Society of Cardiology and the ACC/AHA. But if you look at it, I've summarized it to put with the two dotted lines. The dotted lines in green on your right, it shows that patients age 75 or 80 and above, the preference is to get a TAVI procedure. This is quite accepted generally now, irrespective of risk. However, the dotted line, everything to the left of the red dotted line, patients 65 and below, the preference is to get a surgical aortic valve replacement. That was the guidelines. Guidelines are being made to guide us, but look at this real-world data. Patients 65 years and below in North America, specifically in the US, looking at large centers in Estonia, New York, and New Jersey. About 1/3 of the patient gets a TAVI valve, less than 65. We can debate about this. Surprising to me data. And what are the outcomes? This was against the guidelines. The guidelines, of course, the data showed within the unmatched and the more robust propensity match cohorts comparing TAVR and SAVR, the mortality rate was much higher in terms of the TAVR valve. So I think you need to have a very compelling reason why you want to use TAVR in these young patients. Now, so the first question we answered. Second question, a mechanical valve versus the tissue valve. This is the guy going back to the guidelines again in aortic valve replacement. Quite simple, more than 65, tissue valve is preferred, less than 50, mitral valve is preferred, and in between group of 50 to 65, the new middle age group. This is, as touched by, emphasized by Dr. Bono, patient's preference, and a case discussion between physician and patients is a class 1 indication. Now, when we looked at this is based on data that has now come in. This is very recent data looking at bioprosthesis versus mechanical AVR. This data of this year in the JACC shows a large series of patients looking at which is the cutoff point for the preference. Survival is better with the mechanical valve at 60 and below. The hardest on that turn, we're not looking at the MACE rates. This is pure heart robust survival. 10-year survival, advantage less than 60. More than 60, then you can see the bioprosthesis predominates. There are more papers into that and also looking at the same data. So at different age points, in fact, you go as high as 70 years old, it shows a survival advantage of mechanical valves over tissue valve. So second question, we answered mechanical better than tissue. Yeah, in the age group 60 and below. Is Onyx valve different from any of the other mechanical valves? So what's special about this Onyx valve? So Onyx valve is, I'm not sure whether many of you have experienced using this valve. This valve was what is known as a second generation bileaflet valve because it has special properties. The three listed here, it has a leaflet that opens 90 degrees up. The other leaflets open less than 85 degrees. With this, it promotes laminar flow and straight flow through the orifice of the valves. It is made from pure pyrolytic carbon. Pure pyrolytic carbon, the other mechanical valves are made by alloyed carbon. The difference between pure pyrolytic carbon with a single material is very smooth. There are hardly any rough edges, especially in the pivot, especially in the crevices areas, and this leads to very low thrombogenicity. And it has another additional flat inlet design at its inlet, and this is now flat out. This is done to prevent penis ingrowth. So there are many perceived advantages of this valve. Proof of concept, this valve was tested in the PROACT trial. 2014, this trial was introduced looking at, because of the advantages of this new generation mechanical valve, whether a lower anticoagulation would have the desired results. Anticoagulation target was labeled at 1.5 to 2.0 as opposed to the more accepted for the other bileaflet valves in the aortic region, which is 2.0 to 3. And you can see in this graph there, lower anticoagulation did not lead to any increased risk of thrombosis or thromboembolism. With the advantage of lower anticoagulation, it has a protective effect into severe bleeding rate. So this actually showed a very big advantage of this mechanical valve compared to the other. Low anticoagulation, no increased risk of thrombosis, but reduced risk of bleeding. That is 2014, 5 years on. This is the newest data. Now the ONEX now has gone 10 years. So this is the update. It's an important update. Paper presented last year. Paper presented last year looking at the outcomes of 10 years, 5 years after the PROACT trial. And it had looked at endpoint of looking at thromboembolism and bleeding rates. Compared to the other mechanical valves with higher anticoagulation, the ONEX valve has showed a reduced 66% low INR group in composite index. When they look at the major bleeding, 87% reduced, 87% compared to the other mechanical valves which needed a higher anticoagulation. And there was zero valve thrombosis. So what does this mean? These results mean at the lower INR with the ONEX aortic valve, it has protection against thromboembolism at the lower, while it reduces the bleeding rate. So this is a valve that has a very good risk profile and is advantageous for many of our patients, especially when we're looking at the younger group who has a long time to live in the life expectancy. So we put all these three questions that I raised initially: SAVR versus TAVR, patients in younger than 65, SAVR; mechanical versus bioprosthesis, patient less than 60, mechanical valves. The ONEX valve, is it better? There are advantages shown in the PROACT trial and the post-PROACT trial as recently published up to 10 years. Now, let's switch gear again. So we answered all these three questions we just summarized. So I might switch gear to the mitral position. In the mitral, as with the aortic position, it's just more than 65 tissue valve, less than 65 mechanical valve. This is rather simple. Let's look at whether there's any survival advantages based on age. These are two papers looking at. I'd like you to focus on the graph on the right. This is a Goldstein paper, 2017. This look at patients in the mid-age group, middle age group, 50 to 70 years, less than 70. It shows a survival advantage of mechanical valve over the bioprosthesis. This is hard data. So if you're talking about patients in the young, relatively younger age group, there's a survival data needs to be put into the discussion with the patients. And also the ONEX valve in the mitral position shows very good hemodynamics. Hemodynamics in terms of effective valve orifice area. You can see the effective valve orifice area in all sizes. It's at least 2.8 centimeters squared and above, and with gradients of less than 5 millimeter mercury transmitral gradient in all sizes of valves. Excellent hemodynamics across the valve. Why is this important? It's important because when we talk about patient prosthetic mismatch. You can see in the blue circle of the various sizes of valves, increasing sizes, compared to the blue is the on-X valve. It has a fixed orifice across the sizes. We'll talk about this in a short bit. It's always a size 25 millimeter diameter orifice. As compared to the other, the comparison group was the St. Jude valve in red, and you can see it has an increased orifice diameter more in the smaller sizes, but right up to size 33, the on-X valve has an increased EOA and is protective against patient prosthetic mismatch, which has an impact, especially in younger patients, in terms of survival. So these are the two available on-X on-X mitral prosthesis. The previous generation was a standard cuff. It comes in 3 different sizes. The one that's more recently introduced is the Conform X. It has a single size 25 millimeter valve. The difference is in the Conform sewing ring, which is now you do not need to size. This is a one size fits all for anything from 25 mm to 33 mm. The reason behind that, the philosophy behind that is in a 25 mm, you have excellent hemodynamics. You do not need anything larger than that. So other valves need larger size to accomplish these low gradients and effective orifice area, but not the on-X valve. So what are the clinical benefits of this new on-X mitral Conform X? Because this flange, the sewing in is large, now but you can put the valve in an atrialized mitral implantation position. So the housing of the valve goes into the smaller or calcified mitral orifice. The flange stays above it, so you can put it in a small or calcified mitral valve. And it minimizes, because of a large sewing ring cuff, it minimizes paravalvular leak. So the take-home message in this short presentation, Mr. Chairman, ladies and gentlemen, surgical aortic valve with the mechanical prosthesis has superior survival compared to bioprosthesis, compared to TAVI in patients less than 65 years old. In the PRO-ACT trial, the on-X aortic valve with low anticoagulation, 1.5 to 2, has a protective effect in reducing the risk of major bleeding by a whopping 87%. In terms of the mitral Conform X, this is very suitable because good hemodynamics and a good flange sewing cuff for calcified and small annular. And also, because of its good hemodynamics, it negates patient prosthetic mismatch. Collectively, these features in these updates makes this valve very suitable for younger patients with a longer life expectancy. This is my final slide. Interestingly, when I look back at my practice, I was the first person to put on-X valve, because this valve has been hovering around in the fraternity, but nobody took up the challenge to use it because lack of data. So I met the person who implanted several of it in South Africa in 2011. And we had a chat over coffee, and he showed me his data, which was extremely interesting. In poor anticoagulated South African patients, the thromboembolic rate was extreme. The Western world, and this led to the PRO-ACT trial. Well, I took a leap of faith and I started using it, and I started using it since 2011, before the PRO-ACT trial. Thank you very much for your kind attention.
Good morning. My name is Farhan. I'm a general practitioner from Cirebon. It is an amazing event that I had lucky to attend this event. I want to ask a question regarding the future of the cardiothoracic and vascular surgeon. I just read that weeks ago that maybe cardiothoracic surgeon, some said that it considered maybe that specialty because the cardiologists currently improving in the percutaneous or minimal invasive in valve replacement. But in the recent years, the interesting fact that some surgeon like to take the cardiothoracic fellowship because there is improvement in the endovascular that conducted by the cardiothoracic surgeon. And I would like to know what is the future of the cardiothoracic surgeon in Indonesia and in the world, because the world is also now take the cardiothoracic surgeon into the endovascular surgeon. And that is what in Indonesia and maybe in Philippines had done in the first place when they built the cardiothoracic and vascular surgeon. Thank you in advance.
Thank you. I would like to conclude for all speakers, this is a nice question from the general practitioner. Maybe he would like to be in the future to be a cardiothoracic and vascular surgeon, but he still doubt what is the future of ours working in a cardiothoracic vascular surgery. So maybe I will ask first from Dr. Bono from Indonesia. Bagaimana sih masa depan seorang ahli bedah TKV terkait dengan bidangnya, Dok? Karena memang sebenarnya sekarang ini di masa depan kita sudah menginjak ke area minimal invasif ya, baik di bidang bedah torak maupun kardiak maupun vaskular. Mungkin Dr. Bono bisa kasih sedikit opini.
I will give the answer first as a junior before the seniors. So I think we must not forget the patient safety first. Yeah. It's very. I know that nowadays, I think every surgeons maybe wants to learn about the minimal invasive surgery, and sadly they put it at the top of the patient safety. So I don't think that this is a very good conduct. For instance, like I was told that the repair is always better than replacement, for the longer term. But since we choose the way to do it at minimally invasively, limited field, limited operation field, and the patient end up with a replacement or worse. We have to know our limitation, because I think for the knowledge there are no limitations. The transfemoral transvascular valvular replacements nowadays is getting more and more popular. Several companies, several industries now develop their own TMVR or aortic valve replacement. TAVI is getting more and more popular. But as Dr. Jeswan showed, now for the low risk TAVI, for instance, for example, it's not giving a very good result in the long term compared to the SAFR. So I think the future is going to be not everybody doing catheterly, but still place we have to do surgically, and I think we have to put the patient's safety first above other measures. Minimal invasive surgery compared to sternotomy, for instance, there's no difference after 5 months of the procedures. The people will have the same quality of life after 5 months, regardless of the sternotomy or minimally invasively. But repair or replacement is going to affect the patient for the life. So we have to put it in our mind. No doubt the future technologies will be more minimally invasively. but there's still some limitation. Maybe that's
Thank you, Dr. Bono. Maybe the next opinion is come from international speaker from Dr. Jason or Dr. Marvin. What is the future of the cardiothoracic surgeon? Is it still interesting to be a cardiothoracic surgeon for the general practitioner, or we should leave it, or we can go to directly to the cardiologist, or maybe like that?
Thank you, Ivan. I think it's a very interesting thought, but we've been to this question before when stents came in, balloon and stents, and I said they're going to replace cardiac surgery and CABG, but you see it's level out. Now if anything, I don't think anyone has a drop of their volume of CABG. It's still very alive and kicking. Now it comes to valves with structural heart disease. We're going through the same thing as well. So aortic valve disease, maybe endovascular as well. But it surprises me because as a generation of surgeons, we are the ones who are usually by discipline, by background, we are the aggressive discipline. But the interventional cardiologist seems to have taken that another step. So we are kind of the moral conscience, the moral complex. Look at the data and see which procedure is better for which patient. And it will level out. But I like what Marvin mentioned, what Dr. Martinez mentioned, that it's not that we should rest on our laurels, we should adapt. That's the survival of the fetus. And adaptation means a change in our practice, how we do cardiac surgery. It's not all through full big stenotomy, not big surgery, big surgeon, no. There are roles for minimally invasive, there are roles for endovascular, there are roles for transcatheter skills. So for the young generation, keep going in cardiothoracic surgery, but go into the newer technologies. There will be places for this for your patients. Not to rival the cardiologist, it's for the betterment of the patient.
Thank you, Dr. Jason. Maybe Dr. Marvin, there is some opinion from you.
Yeah, for the general practitioner, I'm gonna try to invite you to the good side, not to the dark side. So technically, in my mind, it should be a collaboration. For interventional cardiologists, there are some subset of patients that needs transcatheter, especially for PCI or TAVI, or transcatheter valve-in-valve. However, remember, you should think to the future, meaning every patient, you need to think of him as an endless patient. Even if you do a open surgery, you need to think of him in the future. 10 years, 15 years down the road, you will see this patient coming back to your office. Now, the difference between transcatheter and surgical valve is that durability. Remember, transcatheter valve, it will only last you around 5-10 years. Then it will come back, especially for TAVI. Then you need another TAVI. And then after that, what does the patient need? Then you need to remove everything out. In the US, the highest number now of surgery is explantation of TAVI valve. I think you need to think of your patient as a lifetime patient. Think of the future. If you place a surgical valve now, give it like, if you place an onyx valve, the durability is longer. If you place a bioprosthetic valve, I think from the Edwards standpoint, it's around 25 years. And it will fail, surely it will fail. Then what's your next step? Then you can come in with a TAVI valve, especially for low young risk patient. Now, if you offer this patient a smaller incision, a better quality of life, then this patient will come back to you. And if you improve your skills from sternotomy to minimal invasive, now the future is robotic, then cardiothoracic surgery is very beautiful in the future. Then you'll have a better playing field, meaning you can do different types of valve, not just mitral valve, not just like tricuspid valve. You can do triple valves with robotic cardiac surgery, with minimal invasive procedure. Small incision, and this patient can go back to what they're doing in 3 weeks' time.
Thank you, Dr. Marvin. Since our time limitation, I will end up discussion session, and I would like once again thank you for to our invited guest speaker and Professor Nutapong as my moderator, and we will give some souvenir to our speaker. Maybe Professor Nutapong can. Saya mungkin undang ketua himpunan atau wakil ketua himpunan atau ketua panitia Dr. Yan Sembiring.
Selamat pagi rekan sejawat sekalian. Kita lanjut ke sesi berikutnya. Kalau tadi bedah jantung dewasa, sekarang kita lanjut ke sesi bedah toraks. Dengan topik lung cancer, karena nanti juga sudah ada rencana acara pembukaan segera, maka waktunya sangat singkat. Dan dari 3 pembicara, 1 pembicara Mr. Vladimir Anikin di-reschedule menjadi besok. Pembicara pertama adalah Dr. Dihintia Jiwangga Sutawirarno dari Surabaya, pakar bedah toraks Indonesia. Beliau akan membawakan materi mengenai pembedahan untuk kanker paru stadium lanjut lokal, surgery for locally advanced lung cancer. Pada Dr. Tio dipersilakan waktunya 10 menit.
Ya, Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Terima kasih kepada komite yang sudah mengundang untuk bicara di sini. Slide bisa ya. Saya sebelum mulai, saya mau menanggapi pertanyaan yang tadi, bahwa bagaimana future dari BTKV. Sejujurnya dalam hati saya, BTKV itu yang paling keren. Bedah mana coba? Yang operasi jantung, paru, pembuluh darah dalam satu pendidikannya. Itu yang paling luar biasa menurut saya. Oke. Terima kasih. Nama saya Dintia. Saya lahir dari Universitas Airlangga dan saya bekerja di Rumah Sakit Dr. Sutomo Surabaya. Saya diminta untuk bicara 10 menit terkait surgery for locally advanced lung cancer. Saya rasa nggak mungkin. Saya akan bicara agak cepat, tapi semua slide saya ini kalau mau di-copy silakan. Ya, saya akan bicara dalam beberapa topik, dan yang pertama adalah saya mau jelaskan apa itu locally advanced NSCLC. Jadi dalam lung cancer itu ada 3 pembagian secara besar. Kalau pasien datang pada kita akan melihat dia ini di stage atau stadium yang mana. Apakah early stage? Dikatakan early stage itu stadium 1, stadium 2. Dikatakan locally advanced itu adalah stadium 3. Dikatakan advance itu adalah stadium 4. Jadi kalau dia udah ada metastasis, itu udah stadium 4. Kita nggak boleh operasi. Kalau stadium 1, dia masih clear. Hanya tumornya aja yang kecil, nggak ada lymph node, nggak ada metastasis, kita bisa operasi. Tapi di tengah-tengah itu adalah stadium 3, yang dia itu tumornya invasif atau lymph node-nya besar. Dan lymph node-nya itu ada di mediastinum. Nah, di sini yang kita mau bahas, kapan batasan kita bisa maju, kapan batasan kita mengatakan ini radioterapi atau kemoterapi yang lebih adekuat. Nah, jadi kalau kita lihat staging yang sudah kita pelajari selama ini, kita akan persingkat, yang kita bahas hanya ini. Ya, hanya ini. Jadi kita akan lihat mana di antara stadium 3. Dikatakan locally advanced itu kalau misalkan dia stadium 3. Stadium 3 mana yang bedah itu masih memberikan harapan. Apakah A, B, atau C. Yang pertama kita mau lihat T. Kan ada T, N, and M. T-nya dulu yang kita lihat adalah bagaimana T-nya itu. T itu ada macam-macam. Kalau untuk T3 itu dia bisa invasif pada parietal atau perikardium, parietal phrenic nerve, atau dia bisa invasif pada chest wall, atau dia bisa ada dalam satu loop ada 2 tumor. Sedangkan untuk T4 dia ada yang invasif pada trakea atau mediastinum, atau dia invasif pada diafragma, dan dia invasif atau di dalam satu sisi ada 2 tumor tapi beda lobus. Nah, ini yang perlu kita perhatikan. T descriptor T3 sama T4. Karena ini akan menentukan bahwa dia masuk stadium berapa. Ini beberapa kasus yang pernah saya jumpai dalam praktek saya, bahwa yang paling atas itu adalah dia invasif pada diafragma, berikutnya dia invasif pada chest wall, dan yang ini adalah invasif pada vena cava, yang di tengah invasif pada aorta, descending aortic, dan yang sebelah kiri juga sama pada vena cava. Dan sadly, ini yang paling banyak kasusnya di negara kita. Di Indonesia ini luar biasa. Kita jarang sekali dapat yang early stage. Karena tiap kali kita dapat tumor yang kecil-kecil, itu selalu kita pikir, mungkin ini tuberkulosis. Mungkin ini adalah small nodule yang dia infeksi. Nah, kita harus merubah pola itu. Kita harus pastikan, justru kita harus pastikan, kalau ini adalah suatu lung cancer, bayangkan aja berapa lama kita delay untuk tata laksana yang seharusnya dia bisa mendapatkan suatu kesembuhan yang paripurna. Nah, berikutnya kita bicara N. N itu kalau N1 dia peribronchial lymph node itu nggak ada masalah, masih early stage, masih bisa kita bilang early stage. Tapi kalau dia sudah mediastinal lymph node, yang dia tuh lymph node-nya sudah di subcarina, atau di paratrakea, atau di aorta, atau di esophagus dan ligamentum inferior, maka itu sudah dikatakan sebagai N2. Di sini kita bisa lihat bahwa, di kolom yang sebelah sana itu saya kasih kotak merah bahwa itu yang dimaksud dengan N2. Jadi kalau misalkan kita mendapatkan N2 itu ada single, ada multiple, ada bulky. Bulky itu besar artinya. Bulky itu dikatakan bulky itu kalau misalkan dia di atas 3 cm. Selama ini kalau kita melihat dari CT scan, kita akan melihat berapa ukuran lymph node di mediastinalnya. Subcarinal lymph node yang paling gampang kita lihat. Begitu potongan aksial CT scan, kita lihat di bawahnya karina, kita melihat kalau ada penebalan, kita curiga ini adalah suatu penebalan dari mediastinal lymph node, yaitu subcarinal lymph node. Biasanya kita pastikan dengan PET scan. Dari PET scan ada uptake dari radioaktif, maka ini confirm adalah suatu metastasis dari tumor Nah, yang berikutnya bagaimana kita melakukan strategi pembedahan atau strategi tata laksana tepatnya. Yang pertama adalah, ini adalah bervariasi. Stadium 3 itu bervariasi. Yang saya katakan tadi bahwa dia bisa tergantung dari T-nya berapa. T-nya itu apakah dia satelit nodul, apakah dia invasif nodul. Kalau dia invasif, maka tadi kita lihat dia lengketnya kemana. Ke diafragma, ke aorta, atau ke lain-lain, itu akan menjadi pertimbangan. Dan yang berikutnya adalah lymph node-nya. Lymph node kita harus lihat, dia single station atau dia multi station, ada di banyak tempat, dan yang paling penting lagi adalah dia besar, bulky, di atas 3 cm, atau dia kecil, di bawah 3 cm. Itu yang menjadi suatu problem yang harus kita bahas. Semua kasus-kasus yang dia locally advanced harus kita diskusikan. Karena sekali lagi yang kita lihat adalah angka survival. Dan kita punya segala macam perangkat diagnostik yang bisa kita pakai untuk menegakkan staging. Kita bisa menggunakan CT thorax yang paling umum, ada PET scan, lalu kita bisa lebih confirm lagi apakah dia positif atau tidak dengan menggunakan transthoracic biopsi atau transbronchial biopsi, atau menggunakan mediastroskopi, atau menggunakan VATS atau FAMLA. Nah, ini yang saya katakan, kenapa kok kita harus menentukan staging masing-masing pasien kita untuk lung cancer, karena sekali lagi outcome-nya itu adalah angka survival. Kita harus tahu bahwa pasien yang kita lakukan, jangan sampai dia mengalami perburukan. Malah tujuan kita itu mengoperasi supaya dia itu bisa lebih lama hidupnya. Walaupun kita tahu bahwa semua itu takdir itu Tuhan yang pegang. Tapi kita berusaha bahwa secara keilmuan kita harus bisa mendapatkan angka survival yang bagus. Dan angka recurrence yang juga lebih panjang. Nah, di sini dikatakan, kalau misalkan dia stage 3A, T-nya itu masih solid, bukan yang invasif, dengan N-nya itu yang 2, itu masuk 3A, itu masih bisa kita operasi, karena angkanya masih bagus, angka survival maksud saya. Tapi kalau dia sudah, T-nya itu udah naik, T3, T4, yang tadi kita lihat bahwa T3, T4 itu tumornya sudah invasif. Dia sudah invasif ke perikard, dia invasif ke great vessel, dia invasif ke esophagus, maka jangan dioperasi, karena dia lebih tidak baik dalam hal outcome. Demikian pula dengan N2 tadi yang saya katakan, dia begitu lihat torak foto, lung cancer, ada peningkatan dari diafragma, wah jangan-jangan dia udah invasif pada phrenic nerve, sehingga kita harus berpikir bahwa ini sudah stadium yang lanjut.
Waktunya tinggal 1 menit.
Oh my God. Ya. Dan berikutnya, ini impossible saya bicara seperti ini dalam waktu yang 5 menit. Ya tapi oke lah. Nah, dari N-nya kita harus lihat bahwa N-nya itu harus yang single. Jadi kita perhatikan, kalau dia multiple, N2 itu sebelum ada yang terbaru, ya, TNM yang terbaru, dia tuh N2 tidak boleh dioperasi. Nah, sekarang jadi grogi saya. Sekarang sudah ada sedikit bargaining. Kita boleh operasi kalau misalkan dia single, karena dia memiliki angka survival yang bagus. Tapi kalau misalkan dia multiple, maka angka survivalnya tidak begitu baik. Bahkan tempatnya pun itu juga ditentukan atau ditunjukkan bahwa kalau misalkan dia lymph node-nya itu ada di 2 dan 4, itu adalah paratracheal, maka dia masih memiliki angka survival yang oke lah. Dibandingkan kalau dia subcarinal lymph node, stasiun 7, itu lebih jelek. Jadi kalau misalkan subcarinal lymph node-nya itu positif, apalagi kalau misalkan yang positif semua, ini positif, itu positif, maka lebih baik jangan dioperasi. Karena itu akan membuat angka survival yang tidak baik untuk pasien. Nah, ini juga begitu, lebih baik kita mengetahuinya preoperatif daripada kita tahunya pada saat pembedahan. Dan di sini bedah toraks sebagai leader, kita harus menentukan diskusi dengan, dibuat suatu multidisiplin tim dengan paru, dengan radiologi, dan semuanya untuk kita diskusikan. Pasien ini masuk staging yang mana, dan tindakan kita harus bagaimana. Nah, di sini, kalau misalkan dia tidak masuk tindakan pembedahan, kita tidak bisa operasi, atau mungkin operasi tidak akan memberikan suatu hasil yang baik, maka pilihan kita adalah neoadjuvan. Atau kita langsung ke adjuvan kemoterapi atau radioterapi. Nah, ini untuk yang early stage, udah pasti, bedah nomor 1. Karena sudah terbukti memberikan angka survival yang bagus. Tapi kalau dia sudah stadium 3, yang saya katakan locally advanced tadi, maka wajib diskusi. Kita wajib diskusikan. Ini arahnya mau kemana? Kita mau masuk bedah atau kita mau neoadjuvan, melakukan suatu radioterapi atau kemoterapi. Kapan bedah itu mengatakan bahwa ini saya mau ambil kasusnya, ini saya mau operasi? Syaratnya nomor 1 adalah kita harus bisa mencapai complete resection. Kita harus bisa mencapai R0 atau at least R1 kalau misalkan nanti dilihat dari hasil mikroskopik. Lalu yang berikutnya tidak boleh N3. Jadi N3-nya nggak boleh positif. N3 itu dikatakan kalau dia lymph node-nya membesar di extrathoracik, di supraklavikula, di coli gitu ya. Jadi kalau misalkan N3-nya sudah positif, ya nggak boleh kita operasi. Terus yang berikutnya adalah kita harus yakin atau lihat pasiennya itu operable. Kalau pasien dalam kondisi yang tidak operable, yang artinya bahwa dalam waktu 90 hari atau yang disebut dengan perioperative mortality, itu tidak terjadi, maka kita bisa operasi. Tapi kalau pasiennya dengan Karnow-Swiss score yang tidak bagus, performance score yang nggak bagus, ya jangan dipaksakan untuk operasi, karena itu terlalu jelek. Nah, saya belajar dari ada suatu survei dari European Research and Treatment Cancer. Mereka mempermudah pemikiran kita. Kalau kita terima pasien locally advanced lung cancer, maka kita tinggal lakukan operasi kalau dia di garis yang hijau atau di jalur yang hijau. Kalau jalur yang kuning, itu tidak ada persetujuan. Mereka juga nggak yakin. Kalau jalur yang merah, no, jangan dioperasi. Dangerous. Atau pasien akan mengalami suatu angka yang tidak baik. Di sini dikatakan bahwa semakin tinggi angka T-nya, semakin tinggi staging T-nya, tapi selama N-nya itu masih N0 atau N1, maju, kita bisa reseksi. Atau kalau T-nya itu masih early, masih T1, T2, N-nya agak sedikit ke arah kiri, kita tetap maju. Tapi asalkan kalau dia masih single. Kalau udah multiple atau yang bulky, yang besar, 3 cm lebih, jangan dioperasi. Karena mereka semua sepakat itu tidak akan memberikan hasil yang baik pada pasien. Oh maaf, ini juga yang penting harus saya sampaikan. Di kolom yang sebelah kiri atau di diagram yang sebelah kiri dikatakan, bisa maju reseksi kalau misalkan dia lengketnya hanya di parietal atau di chest wall. Karena kita bisa rekonstruksi. Tapi kalau misalkan dia sudah lengketnya sampai ke perikardium, parietal perikardium, atau dia kalau yang T4, dia sampai menempel jantung, invasif pada jantung, maka lebih baik jangan dilakukan reseksi. Karena tidak akan baik untuk pasien. Dari survei yang lain juga dikatakan bahwa hampir sama ini, semakin ke arah kiri atau semakin N0, N1, T-nya makin tinggi, itu masih bisa reseksi. Nah, sehingga kita bisa mempersingkat pemikiran kita, kalau misalkan T-nya itu masih bagus, T1, T2, atau mungkin T3, tapi N-nya itu N2, maka kita harus lihat. Kalau N2-nya itu adalah resectable, kita bisa ambil, tapi dia besar, bulky, maka jangan dioperasi. Mereka semua sepakat bahwa itu radioterapi yang bisa menjadi terapinya. Tapi kalau misalkan dia non-bulky, yang ukurannya di bawah 3 cm, maka bedah yang lebih banyak berperan. Tapi kalau misalkan dia N2-nya tidak resectable, yang artinya bahwa lymph node itu invasif, maka kita tidak boleh melakukan tindakan bedahan. Radioterapi, RT itu radioterapi yang mungkin bisa berperan pada pasien. Ini juga sama. Nah, tapi setelah saya mempelajari ini semua, ternyata saya melakukan beberapa dosa-dosa pada pasien saya. Dosa yang pertama adalah saya operasi pasien dengan stadium 3B. Yang harusnya dari komandemen tadi atau dari survei tadi dikatakan bahwa kalau udah 3B jangan dioperasi mestinya. Karena lebih baik atau lebih bijaksana melakukan radioterapi. Ini yang hasil saya operasi dan lymph node-nya saya ambil semua. Dan memang betul, lymph node-nya itu beberapa ada yang positif. Tapi bagaimana kondisi pasien? Nah, sini selama operasi, perioperatif nggak ada masalah, pasien pulang dengan baik, kontrol ke poli juga baik. Cuman di Indonesia kita nggak tahu, angka 1 tahun, 2 tahun, 3 tahun, 4 tahunnya itu bagaimana. Ini sudah 3 tahun berlalu dan saya nggak mendapatkan kabar dari pasiennya. Tapi ya sudahlah, moga-moga selamat. Ini juga sama, saya juga operasi pasien dengan stadium 3A, tapi dari lymph node-nya sudah dikatakan bahwa dia di stasiun 7-nya besar. Itu ukurannya mungkin sekitar 3 sentian. Nah, kalau dari komandemen tadi atau dari riset tadi dikatakan bahwa kalau dia lymph node-nya besar, bulky, jangan dioperasi. Radioterapi yang paling bagus. Tapi ini saya operasi. Karena ini saya tahunya atau saya melakukan tindakan ini sebelum adanya komandemen atau survei tadi itu. Tapi nggak ada masalah. Ini untuk pembelajaran kita semua. Oke, akhirnya sampai ke take home message. Yang pertama adalah locally advanced lung cancer. Itu semuanya adalah harus diskusi. Tidak bisa kita putuskan sendiri. Karena demikian detailnya kita harus melihat berapa T, berapa N. M itu kalau 1 maka nggak mungkin dioperasi. M-nya harus 0. Tinggal T atau N-nya yang harus bagaimana kita harus lihat. Yang berikutnya kita harus mencapai namanya R0. Jadi local control, surgery control itu memang harus kita yang melakukannya. Dan yang berikutnya stadium 3A itu yang paling bisa atau memungkinkan untuk mendapatkan hasil yang baik. Dan yang tentunya yang saya harus tekankan, N2 kalaupun positif maka dia harus yang single, jangan yang multiple. Dan kalau bisa jangan yang besar. Kalau yang besar lebih baik radioterapi. Tidak ada di sini maka kita harus masuk ke radioterapi ke neoadjuvan. Demikian, terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Baik, terima kasih Dr. Tio atas presentasinya yang cukup jelas dan sangat informatif ya. Untuk selanjutnya mungkin kita tunda dulu pembicara berikutnya, kemudian dilanjutkan dengan pemberian plakat juga nanti Dr. Tio ya setelah pembukaan, dan mungkin juga diskusinya juga akan kita simpan setelah acara pembukaan. Mungkin sementara itu kita turun dulu dan kita bisa lanjut dengan acara pembukaan. Terima kasih.
Good morning and welcome to Ministry of Health of the Republic of Indonesia, Mr. Budi Gunadi Sadikin.
Selamat pagi dan selamat datang kami ucapkan kepada Menteri Kesehatan Republik Indonesia, Bapak Budi Gunadi Sadikin.
Good morning, distinguished guests, ladies and gentlemen. The 5th Asian Academic Pediatry, Cardiac and Heart Surgery, and the 16th Annual Scientific Meeting of HBTKVI 2025 is about to begin. The opening ceremony will begin shortly.
Kami ucapkan selamat pagi kepada para tamu undangan yang kami hormati, hadirin sekalian. Acara The 5th Asian Academic Pediatric, Cardiac and Heart Surgery and the 16th Annual Scientific Meeting of HBTKVI 2025 akan segera dimulai.
Ladies and gentlemen, please rise for the national anthem of Indonesia, Indonesia Raya.
Hadirin dimohon berdiri menyanyikan lagu kebangsaan Indonesia Raya.
Ladies and gentlemen, please remain standing as we sing the HBTKVI March.
Hadirin kami mohon tetap berdiri, bersama-sama kita akan menyanyikan Mars HBTKVI.
Thank you, ladies and gentlemen. You may now be seated.
Terima kasih. Hadirin dipersilakan duduk kembali.
Good morning, ladies and gentlemen. Welcome to the 5th Asian Academic Pediatric, Cardiac and Heart Surgery and the 16th Annual Scientific Meeting of HBTKVI 2025. Let's give a big round of applause.
Dan tentunya sekali lagi kami ucapkan selamat pagi dan selamat datang hadirin sekalian yang telah hadir di Pulau Dewata Bali ini.
And allow us to introduce ourselves. My name is Chandra Cardana and my partner Nana Viana. As your master of ceremony for today's remarkable event, it is a great honor for both of us to welcome you to Bali, the island of paradise.
Dan tentunya sekali lagi perkenalkan saya Nana Viana dan rekan saya Chandra Cardana, merupakan sebuah kehormatan bagi kami memandu acara istimewa hari ini dan senang sekali menyambut Anda semua di Pulau Dewata Bali ini.
This event brings together distinguished cardiac, thoracic and vascular surgeons from across all of Indonesia and around of the world, united in the spirit of sharing knowledge, expertise, and innovations.
Hadirin undangan yang berbahagia, acara ini mempertemukan para dokter bedah torak, kardiak, dan vaskular dari seluruh Indonesia dan mancanegara dengan semangat berbagi ilmu, keahlian, dan inovasi.
To begin with, please allow us to extend our warmest welcome to Honorable.
Memulai acara pada hari ini, izinkan kami menyapa tamu kehormatan yang telah hadir pada hari ini.
Minister of Health of the Republic of Indonesia, Mr. Budi Gunadi Sadikin and Mrs. Ida Sadikin.
Good morning.
Welcome to Bali.
Good morning and welcome to Director General Advanced Health, Ministry of Health of the Republic of Indonesia, Mr. Azhar Jaya. Good morning.
Director General of Health Workforce, Ministry of Health of the Republic of Indonesia, Mrs. Yuli Fahrianti. Selamat datang, Ibu.
Good morning and welcome to Director Professor Ngurah Hospital, Mr. Iwayan Sudana. Selamat pagi.
The Dean of Faculty of Medicine, Udayana University, Mr. Januarta Putra Pinati.
Good morning and welcome to Chairman of the Indonesian Association of Thoracic, Cardiac and Vascular Surgeon, Mr. Prasetyo Edi.
Chairman Collegium BTKV Indonesia, Mr. Putu Yasa.
Good morning and welcome to Chairman of the Organizing Committee, the 16th of PIT HBTKVI 2025, Mr. Ian Efrata Sembiring. Selamat pagi.
President of the 5th Asian Association for Pediatric Congenital Heart Surgery, Mr. Budi Rahmat. We also would like to express our sincere gratitude to respected professors, speakers, committee members, partners, and participants. We welcome you all and thank you for making the time to join us today.
Dan kami juga mengucapkan selamat datang kepada yang kami hormati para profesor, para pembicara, para kolega, serta seluruh peserta yang telah hadir pada acara kita hari ini.
To begin this ceremony with blessing, let us take a moment for prayer.
Berdoa mulai. Berdoa selesai.
Ladies and gentlemen, it's now time to hear the welcoming remarks. First, we would like to invite the chairman of the organizing committee, Mr. Ian Efrata Sembiring, to come to the stage.
Sekali lagi untuk itu kepada yang terhormat Mr. Ian, kami persilahkan.
Terima kasih MC. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, salam sejahtera bagi kita semua. Namo Buddhaya, salam kebajikan. Yang kami sangat hormati Bapak Menteri Kesehatan Republik Indonesia, Bapak Budi Gunadi Sadikin beserta Ibu, yang kami hormati Bapak Dirjen Keslan, Ibu Dirjen SDMK, Bapak Direktur Rumah Sakit Umum Pusat Ngurah, dan Bapak Dekan Fakultas Kedokteran Universitas Udayana, Kolegium, Ketua Kolegium Bedah Torak Kardiak Vaskular dan Ketua Perhimpunan Bedah Torak Kardiak Vaskular, serta para senior dan teman sejawat HBTKVI, para hadirin serta peserta simposium yang kami hormati. Pertama-tama marilah kita panjatkan puji dan syukur kehadirat Tuhan Yang Maha Esa, karena berkat rahmat dan karunia-Nya kita bisa berkumpul di sini. Tadi Pak Menteri sangat surprise melihat ruangan penuh dan sampai berdiri, mohon maaf. Karena kita ketahui bahwa pada minggu lalu kita baru saja menjalani suatu peristiwa yang cukup menegangkan di negara kita. Tapi sekali lagi karena rahmat Tuhan Yang Maha Kuasa, kita bisa berkumpul dengan keadaan yang baik dan sehat pada hari ini. Pada hari ini kita akan menyelenggarakan pertemuan ilmiah tahunan HBTKVI yang berkolaborasi dengan Asian Association of Pediatric and Congenital Heart Surgery. Kami selaku Ketua Panitia Penyelenggara merasa sangat terhormat atas kehadiran Bapak Menteri Kesehatan dan Ibu, Bapak dan Ibu Dirjen, Bapak Direktur Rumah Sakit Ngurah, dan Bapak Dekan, di mana kami menganggap kehadiran Bapak dan Ibu ini adalah bukti nyata dukungan terhadap perkembangan ilmu pengetahuan dan pelayanan kesehatan, khususnya di bidang bedah torak, kardiak, dan vaskular di Indonesia. Ladies and gentlemen, we are also very delighted to warmly welcome to our distinguished international speakers and participants who have traveled from various countries. Your enthusiasm and presence, despite recent challenges in our country, are truly inspiring. Almost all our invited foreign experts are here today. So almost 100% presence, no cancel, regarding to the new issue in our country. This is a remarkable testimony of friendship, solidarity, and commitment to science. Hadirin yang saya muliakan, PIT HBTKVI kali ini tidak hanya menghadirkan simposium ilmiah, tetapi juga workshop yang komprehensif. Mari kita saksikan video singkat mengenai workshop yang telah dilakukan kemarin. Workshop ini dirancang untuk para dokter spesialis bedah torak, kardiak, dan vaskular untuk meningkatkan dan memperdalam keterampilan melalui hands-on training bersama para pakar internasional dan nasional. Kami laporkan juga kepada Bapak Menteri Kesehatan, tahun ini kita juga menyelenggarakan workshop untuk para dokter umum, khususnya yang bertugas di daerah yang terpencil, 3T, dan yang belum memiliki dokter spesialis. Di mana dengan pelatihan ini, para dokter umum akan mendapatkan kompetensi tambahan untuk menghadapi kondisi gawat darurat pada kasus bedah torak, kardiak, dan vaskular. Seperti kita ketahui bahwa kegawat daruratan pada bedah torak khususnya kadang-kadang tidak memungkinkan untuk dilakukan rujukan ke rumah sakit yang lebih tinggi. Sehingga diharapkan dokter umum yang merupakan garda terdepan dalam pelayanan kesehatan kita, itu mampu mengatasi kondisi ini sehingga bisa mengurangi angka kematian maupun morbiditas akibat trauma ini. Kami mengharapkan manfaat ini tidak hanya berhenti di ruang simposium, tapi benar-benar sampai pada peningkatan kualitas pelayanan kesehatan masyarakat dari pusat rujukan nasional hingga ke daerah. Ladies and gentlemen, we believe that through this scientific meeting, we are not only sharing knowledge and upgrading skills, but also building a stronger network of collaboration. Together we strive for a future where better healthcare service are accessible for all. Sebagai penutup, izinkan saya menyampaikan pantun. Nah, ini saya juga belajar, orang Batak belajar pantun gitu. Ke tanah Lot melihat senja, ombak berdebur indah sekali. Let's share knowledge, together we care for better health from Bali to all country. Dengan ini saya mengucapkan banyak terima kasih kepada semua pihak yang telah mendukung terselenggaranya acara ini, para sponsor, di mana semoga pertemuan ilmiah ini membawa manfaat yang besar bagi kita semua. Welcome to Bali, welcome to PIT HBTKVI dan AAPCHS. Together, we share knowledge, improve skill, and build stronger collaboration for a healthier future. Wassalamualaikum warahmatullahi wabarakatuh. Shalom dan salam sejahtera bagi kita. Om Santi, Santi, Santi Om. Namo Buddhaya. Terima kasih.
Thank you, Mr. Yan Efratasbiring, for your welcoming remarks.
And now we will continue, ladies and gentlemen, for the second speech. We would like to invite President of the 5th Asian Association for Pediatric Congenital Heart Surgery, Dr. Budi Rahmat. Please come to the stage.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, shalom, namo buddhaya, salam kebajikan. Yang saya hormati, terima kasih waktunya Pak Menteri Kesehatan Republik Indonesia, Pak Budi Gunadi Sadikin dan Ibu Ida, Pak Dirjen Keslan, Pak Azhar Jaya, Ibu Yuli, Dirjen SDMK, Bapak Direktur Ngurah, dan juga dekan, dan tak lupa ketua perhimpunan dan juga ketua Kolegium HBTKV Indonesia. Yang nggak kalah pentingnya kepada seluruh speaker, profesor, peserta, sponsor, dan juga para supporter dari IO untuk kesuksesan acara ini. Pertama-tama, puji syukur kehadiran Allah Subhanahu wa Ta'ala, atas kuasanya lah kita bisa berkumpul bersama, sharing pengetahuan, sharing pengalaman, sharing masalah, dan juga pemecahannya. Ya, it's a great honor for me to welcome you all to the 5th annual meeting of the Asian Association for Pediatric and Congenital Heart Surgery, together with a PIT HBTKVI, the 16th in local Indonesia, but it's the most important for society, cardiothoracic surgery in Indonesia, with participants from 40 countries and also 135 international delegates. This conference is a proof of the strength of global collaboration in advanced healthcare, specifically in the field of pediatric heart surgery. Thank you so much for the presence of our esteemed Minister of Health Indonesia, Mr. Budi Gunadi Sadikin, who has consistently supported the improvement of the health service across the nation, especially in pediatric heart surgery. We are grateful for the government's continuous effort in health system and healthcare access, and we are confident, Bapak, that with your leadership will inspire further breakthrough in this field. As pediatric heart surgeon, we face many difficult cases. One of the most complex in double outlet is the double outlet right ventricle. This is the theme of this annual meeting of AAPCHS. This condition is not easy to understand. That's why we invite the famous heart surgeon across the Asia and also Middle East to come. It's even harder to repair. It has many types and each child is different. To be able to operate double outlet right ventricle safely and successfully means you have the very high level of skill. Many says that a surgeon, especially pediatric heart surgeon, will be the true pediatric heart surgeon only after mastering double outlet right ventricle surgery. I believe this is true. That's why this year's program is so special. We have a complete symposium divided into 5 sessions covering all important topics from E to Z about double outlet right ventricle. And at the end of the meeting, not only theory, we will hold the hands-on double outlet right ventricle surgical workshop with a special design and real printed 3D heart. It designed by Dr. Sakamoto, the current AAPCHS president, from his real patient. So, hopefully this workshop will be accurate and also designed to help young pediatric heart surgeons to improve their skill. Ladies and gentlemen, in this moment, I would like to honor the 32 leading pediatric heart surgeons from Asia and Middle East who have come to Indonesia and are dedicating their time, effort, and commitment to teach young pediatric heart surgeons. Please give them a big applause. Finally, on behalf of the AAPCHS organizing committee, our Indonesian hosts, and all supporting partners, I thank you for being here. I invite you all to take part actively, share your experience, and learn from each other. Let us make this meeting meaningful for ourselves and also for the children we serve. Thank you, terima kasih, arigatou gozaimasu, sisi, kamsahamnida, jazakallahu khair. Assalamualaikum warahmatullahi wabarakatuh.
Well, thank you so much for your speech, Dr. Budi Rahman.
And now we would like to invite the chairman of Indonesian Association of Thoracic, Cardiac and Vascular Surgeon, Mr. Prasetyo Edi.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua yang saya hormati Bapak Menteri Kesehatan, Pak Budi Gunadi Sadikin dan Bu Ida, Pak Dirjen, selamat datang, Bu Dirjen selamat datang. Yang saya hormati Direktur Rumah Sakit Ngurah, Pak Dekan, Ketua Kolegium, Profesor dan Senior PTKV Indonesia, dengan mengucapkan syukur kehadirat Tuhan Yang Maha Kuasa, saya menyambut hangat kehadiran seluruh anggota PTKV Indonesia, tamu kehormatan yang ada di ruangan ini. Kehadiran Bapak Menteri Kesehatan merupakan bukti nyata bahwa kita sama-sama ingin peningkatan pelayanan bedah jantung, bedah torak, dan bedah vaskuler Indonesia ini berlangsung dengan baik. Jadi AAPCHS ini adalah organisasi pediatri Asia. Ini merupakan awal dari kita berkomitmen untuk pelayanan yang merata di bedah jantung anak. Izin melaporkan Pak Menteri, PTKV ini adalah asosiasi bedah yang kompetensinya paling banyak. Mengampu bedah jantung dewasa, mengampu bedah jantung pediatri, bedah torak, dan bedah vaskuler. Jadi ada 250 orang BTKV, sementara kira-kira dibutuhkan 1.200. Kalau kita bicara pediatri, ada 50.000 per tahun. Yang emergensi 17.000. Yang bisa dihandle itu 2.500. Satu angka yang menurut saya luar biasa. Jadi Pak Menteri menyediakan alat-alat itu bagi orang luar dianalisa dengan salah. Tapi bagi BTKV itu sangat bermakna. Jadi itu luar biasa bagi sebuah kilometer nol untuk menuju personel yang satunya, pelayanan BTKV yang selama ini belum bergerak seperti hari ini. Jadi satu hari yang lalu saya ditelepon oleh seorang profesor, bagaimana alat-alat itu dibeli Pak Menteri, bisa kepake enggak? Saya sampaikan full 100% kepake di bidang bedah jantung. Jadi Pak Menteri, kalau misalnya hari kemarin itu pengampuan bedah jantung dewasa, kalau hari ini merupakan start kilometer 0 pengampuan bedah jantung pediatri, maka sebetulnya kita naik kelas. Karena bukan sekedar bedah jantung pediatri itu SDM-nya sedikit, tetapi butuh intensive care, butuh SPJP. Benar-benar kalau misalnya itu bisa terwujud, itu adalah mimpi besar yang luar biasa. Kalau hari ini bedah jantung dewasa itu hanya berjalan di CABG, bedah jantung dewasa bukan hanya CABG. Jadi peran HBTKVI ini pada kontinuitas pelayanan. Bukan sekali operasi di satu tempat, tapi operasi kedua, ketiga, keempat sudah kita coba inisiasi di 3 titik. Minimal di Kupang, di Tarakan, dan insya Allah di Lemena pada awal Oktober. Jadi Pak Menteri di bidang toraks, rasanya kami selalu mendukung apa yang Pak Menteri gariskan kebijakannya. Hari ini kita secara berani memberikan kompetensi pasang chest tube bagi dokter umum. Jadi kalau misalnya Objin ragu-ragu memberikan sesar kepada dokter umum, chest tube itu juga kalau salah pasang, itu bisa nusuk jantung itu. Jadi insya Allah kompetensi ini saya usulkan ada di SKDI. Saya akan kawal, kebetulan saya anggota Majelis Disiplin Profesi, saya akan kawal pertanggungjawabannya di lapangan. Jadi di bidang vaskuler saya punya filosofi bahwa seorang direktur rumah sakit di sebuah provinsi, manakala dia merekrut BTKV, maka dia beli 1 tapi dapat 3. Dia beli bedah jantung, dia dapat bedah torak, dan dia dapat pelayanan bedah vaskular. Jadi kalau misalnya diakhiri dengan pantun, saya ingin mengakhiri dengan pantunnya Aristoteles, Dr. Ian. Jadi Aristoteles itu bilang bahwa Anda tidak akan bisa melakukan apapun di dunia tanpa keberanian. Karena keberanian itu adalah kualitas pemikiran yang tertinggi setelah kehormatan. Hari ini Pak Menteri, himpunan yang bedah jantung, himpunan yang ketua kolegiumnya, itu satu chemistry sama ketua perhimpunan, itu BTKV. Jadi saya akan tunjukkan kepada himpunan di luar sana, bahwa kalau ketua kolegiumnya sudah satu chemistry sama ketua himpunan, apapun bisa akan kita keluarkan produknya dengan keberanian itu. Keberanian memberikan CABG OFPAM untuk menjadikan kompetensi SP1. Keberanian memberikan pasang selang dada chest tube yang bunuh manusia itu kita berikan kepada dokter umum. Jadi akan saya buktikan di luar sana bahwa kalau sudah ketua kolegium itu bersatu dengan ketua himpunan, maka tidak ada satupun yang bisa menghalangi untuk sebuah perkembangan. Itu saja, saya akhiri, wabillahi taufiq walhidayah. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Ms. Prasetyo. Please remain on stage as we will proceed to the inauguration of new graduates.
And for that, I would like to invite to join on the stage Minister of Health of the Republic of Indonesia, Mr. Budi Gunadi Sadikin, Director General Advanced Health Ministry of Health of the Republic of Indonesia, Mr. Azhar Jaya, and Chairman of Organizing Committee, Mr. Ian Efrata Sembiring, to come to the stage.
And now we will proceed with the inaugurations of new graduates of thoracic, cardiac, and vascular surgery specialists. We would like to invite Dr. Nico as the Secretary General of HBTKVI to lead the sessions.
Sekali lagi kami mengundang Dr. Nico selaku Sekretaris Jenderal HBTKVI untuk dapat memimpin jalannya acara selanjutnya. Kami persilakan.
Cek, ya, baik. Kami akan memanggil para yang akan dilantik oleh Bapak Menteri, Ketua Kolegium, Perhimpunan, Ketua, Wakil Ketua. Silakan slide. Siap, calon. Baik. Dr. Ilman Ilma Januar, SPBTKV MKet Clean dari Fakultas Universitas Airlangga, asal daerah Kembali, Sulawesi Tengah. Silakan. Dr. Muhammad Bagus Rifna Putra, SPBTKV MKet Clean dari FK Universitas Airlangga, asal daerah Kembali, Banyuwangi. Silakan. Dr. Rian Prasdinar Pratama Putra, SPBTKV MKet Clean, Fakultas Universitas Airlangga, Mataram, NTB. Silakan. Dr. Nikadek Sulistianingsih, SPBTKV MKet Clean, FK Universitas Airlangga, Denpasar, Bali. Dr. Daud Yudhistira Sukanto, SPBTKV MKet Clean dari FK Universitas Airlangga, asal daerah Kembali, Palangkaraya. Silakan. Dr. Gusti Ramadhani, SPBTKV MKet Clean dari FK Universitas Airlangga, asal daerah Lamongan. Silakan. Dr. Aditya Rahman, SPBTKV dari Fakultas Universitas Airlangga, asal daerah Semalang. Dr. Nabil Ihsan Ahmad, SPBTKV dari Fakultas Kedokteran Universitas Indonesia, asal daerah Bandung. Next.
Kami mengundang Dr. Gita Zara Haifa, SBTKV.
Asal Bandung.
Kami persilakan untuk dapat melakukan sesi foto bersama kepada Bapak Menkes, kemudian Dr. Yan, Dr. Azhar Jaya, dan juga Dr. Prasetyo Edi untuk dapat berada di tengah. Selanjutnya kita akan melakukan sesi foto bersama. Baik, akan saya pimpin dalam 3, 2, 1. Oke, untuk yang kedua, pose yang kedua, saya pimpin kembali dalam 3, 2, 1. Boleh diberikan tepuk tangan, Bapak Ibu.
Dan selanjutnya jangan kemana-mana dulu, please remain on stage, karena selanjutnya akan ada sesi pemberian plakat dari Ketua Panitia kepada Menteri Kesehatan Republik Indonesia.
Bila boleh, senior kita Prof. Purhito, Prof. Paul, mari Prof. berfoto bersama Prof. Paul.
Baik, selanjutnya kami mengundang Muhammad Fuad Alamsyah dari RSUD Lukas Anembe, Membramo, Papua. Dan selanjutnya atas nama Rosa dari RSU Harapan Bersama Singkawang. Dan yang ketiga adalah Jemia Sura dari RSUD Tanjung Pura. Berikut adalah sesi pemberian sertifikat workshop penanganan kasus emergensi torak oleh kepada dokter umum. Baik, silakan untuk kembali berfoto bersama. In 3, 2, 1. 3, 2, 1. Thank you so much. And now you may return to your seat.
Kepada Bapak Menteri Kesehatan, kami mohon untuk dapat tetap berada di atas panggung.
Karena selanjutnya kita bersama-sama akan mendengarkan speech yang akan disampaikan oleh Menteri Kesehatan Republik Indonesia.
Kepada Bapak Menteri, kami silakan.
Pak Purhito, Pak Paul, rekan-rekan BTKV, ladies and gentlemen, welcome to Bali. 23rd December 2020 was the biggest turning point of my career. I was a banker for 30 years. So my job is to manage the wealth of my clients. Then I became the health minister, which is the primary job is to manage the health of my clients. And to be honest, I feel that it's more fascinating, it's more fulfilling to managing the health of our people rather than managing the wealth of our people. Although my first 18 months is very busy only doing vaccination and COVID management. So only after September 2020, I start learning and doing the real job as a health minister. Something that I learned first time on September 2022 was that many Indonesian people die because, number one, stroke. Around 300,000 registered deaths of Indonesians every year. Number two killer is heart disease, which is related to this event. 250,000 deaths every year. Number three killers is cancer. 234,000 deaths every year. And in this cancer, for men, number one is lung cancer, which is related also with this event. Number two is colorectal, and for women, number one is breast cancer, number two is cervical cancer. So when I speak at this event, at least two of the major cause of death of Indonesian people depends on you. The first one is heart disease, 250,000, and the second one is lung cancer, which is 234,000. And my experience in COVID, if Indonesians have a registered numbers, the actual number is between 2 or 3 times bigger, because the way we are recording, the way we create our registry is extremely poor. So easily I can say the death of heart disease is more than 500,000 every year. The death of cancer easily north to 460,000 deaths every year. So if I focus on heart disease, which is most of you are involved on this disease, what the government is doing, as a banker, my expertise is not only giving money, but also look for money. And that is a very rare skill owned by many health ministers across the world. So in 6 months, I managed to get a $4 billion funding to improve the infrastructure, healthcare infrastructure in Indonesia. The first program that we do related with heart disease, we are deploying 10,000 EKG. Now it's in a pilot project mode with Rumah Sakit Harapan Kita, our National Cardiovascular Center, completed with artificial intelligence and telemedicine services. So we can identify the STEMI indicator if you have a heart disease at 10,000 puskesmas at 7,000 inhabited islands in Indonesia. So we deploy the diagnostic tool to 10,000 primary healthcare clinics at 7,000 inhabited islands of Indonesia to serve 280 million of Indonesians. If the general practitioner identify there is a STEMI conditions, now we are deploying with this pilot project led by Harapan Kita hospitals to do a tenecter-placed single-shot injections for thrombolysis treatment. So we do hope 70%, that is what I've been informed, of the heart disease issues can be solved at the primary care level. Because of 10,000 EKG, with artificial intelligence and telemedicine services, we can identify STEMI and do tenecter-placed single-shot injections. The second program that we are doing, this is quite controversial, is to deploy 514 cath labs in 514 cities. And many people still see this as a ridiculous program. For me, I will try to use it ambitious. Why? Because this is the status when I joined. Out of 514 cities, we only have 43 cities that able to do PCI procedures. If we are talking about stroke, can do thrombectomy procedures. And all the experts told me, Budi, if you have a stroke, you have what we call a golden period. Within 2 hours, you need to treat these patients. The same thing in heart disease. There is a golden period. Somebody say 4, somebody say 6, somebody say 8. I use 6, the average. 6 hours. So in Indonesian geography, if I use US is the country that you know, if somebody has a heart attack in Los Angeles, it doesn't make any sense to bring that person to San Francisco to be treated. You need to have that facility at the same city. Because why? Because you have that golden period. That is a simple argument for me why I need to implement this cath lab at 514 cities. Because if you have the heart attack in Sukabumi, that is a city in West Java, you cannot let the people to be moved to Jakarta or Bandung to get PCI. It will be too late. So we need to implement the cath lab at 514 cities. And when I joined, only 43 cities have this facility. For me, that is the reason why 250,000 people die every year. So we put a very aggressive plan to increase this number of cities. And on the next slide, this is what the condition now. In 2 years, we're able to increase from 43 cities to 112 cities. And I put a very ambitious target to myself and my team. By 2027, 514 cities will have a working cath labs. The money is there. The bid has been done. You know, Philips has won the contract and become very popular because now they will provide 350 cath labs across the country. The problem that they have is the doctors, the cardiac interventionists. That's why then, and we don't have enough school. We don't have enough seat in our existing school to provide 350 interventionists. That is assuming that doctors work 24 hours by 7, which is ridiculous. If we want to have 2 doctors in one city so they can take turn, then we need 700 cardiac interventionists. Additional. So what we do, and you can tell your friends, but asking whether the device can be used or not, we are going to China. We get 120 fellowship seats in China, hands-on, to train our doctors. We go to Japan. We go to South Korea. And hopefully we can sign a deal with India. So we can send 200 every year, interventionists. So we have the cardiac specialists, but we need to do fellowships on interventions. So hopefully by 2027, all of these cities will be green. And I think it's very important for us to be ambitious because we can save between 250,000 to 500,000 deaths every year. So I don't mind to be scolded in the social media because of extremely ambitious, doesn't make sense. But I will still do it. Why? Because it saves lives. And my experience in saving lives is so fascinating. It's so fulfilling, to job in saving lives. Now, what are about the more complicated procedures like open heart surgery? Next slide. When I joined, there are 9 provinces that can do open heart surgery. The queue, 3 months, 6 months, a year. We are lucky if we can get served before we die. And to be honest, I would like to share you also a more saddening information. Indonesia, 280 million population, we gave birth every year 4.8 million babies, like one Singapore. So if you don't have a feeling how big is 4.8 million babies, Indonesia add additional Singapore population every year. The expert told me, Budi, out of 4.8 million babies, 1% of them have a congenital heart disease. 48,000. Every year, Indonesian babies have congenital heart disease. And 25% of this, which is 12,000, have a cyanotic one. They told me that cyanotic and cyanotic is when the blood is messing around, and it makes the baby blues, it's riskier, so you need to be operated very, very soon. So 12,000 babies need to be operated soon, otherwise they will die. When in 2022 I asked, what are our capacities to do pediatric surgery? Because some of you are coming as a pediatric surgery associations. 6 centers, 6,000 babies. So I said, what happened with the rest? Because we have 12,000. All these experts look each other and say, that is what we call a natural selections. Can you imagine? 6,000 Indonesian babies die every year because we don't have this capacity. So I'm talking to many doctors, and I have to thank the associations of thoracic, cardiac, vascular surgeon, because they are the one that share my passion that our job is to save life. Our job is not to fight each other about who is doing what, but our job is to save life. So they're supporting me. It's very rare. Usually because I'm not a medical doctor, I'm the first health minister because not a medical doctor, there are a lot of resistance. Although I think I'm doing the right things, but there's a lot of resistance. So they're supporting me, Budi, let's help you. So next one, I'm very proud to announce now in 2 years, from 9 to 27 provinces. Of course, these 27 provinces that can do open heart surgery, the first time they gave me a promise, we can do 2 things. Because as a banker and engineer by background, I'd like to focus on several things. What are the number one procedures needed to do open heart surgery? Why I put it in the provinces? Because it's more complicated. And as you know, the number of surgeons is very limited. It's only 250. The head of the association said it should be 1,200. But when I do ChatGPT, that is the average. In the high-income country, the ratio is 7.13 for every 1 million. So if I compare to Japan, like example, I put Japan as standard because there is one Japanese professor sitting here. The number of BTKV needed is not 1,200. It's close to 2,000. If you want to follow the high-income country standard. So I have to increase from 250 to 2,000. And if you graduate only 25 per year, then you can easily do calculation. Maybe when Indonesia reach 100 years of anniversary, we even haven't reached a target. So we have to do something better, to improve the number of graduates. But here, you have done a great job. Thank you, because you have been able to increase in 2 years from 9 provinces or state, if you are living in the United States, to 27. The challenge that I give to the team, please make it 34. So all provinces will have the capability to do open heart surgery by 2027, at least before I retire. And of course, then the question is, I'm a very demanding leader. So I said, what can you do? Rank number 1, open heart surgery is valve replacement or repair. Because in Indonesian, we have to call it a heart rheumatology. Yeah. Because the way we treat our children when you give antibiotics is not good, whatever it is, and suddenly we have a lot of valve repair and replacements. They promised me they will do that in these 27 provinces. And number 2, we need a bypass, because bypass is the second most frequent procedures after valve replacement. But I say, what are rank number 3 procedures? Pediatric. So I said, why don't you give a bonus? Instead of those 2, you do also pediatric. And this is a good opportunity because the global experts are here. The Asia experts are here. You please help my team. So we can increase the capacity of all 37 provinces, the cardiac surgeon to do valve replacement, bypass, and pediatrics. And I tell him, what are pediatrics? Number 1, ASD. Number 2, VSD. Number 3, TOF. Number 4, PDA. So give me this 4. VSD, ASD, PDA is easy. TOF is okay. So I said to the association, can you push down the competencies of these procedures down to the specialist level? So then all the specialists, BTKV, can do those 4 procedures for pediatric. We will leaving the complicated, what you call DORF, DORF or TGA or Fontan, Norwood, the most difficult procedures back. Let's do it at the reference hospital. We have Ministry of Health hospitals. It's not in every province. It's maybe 8 to 10 that can do a complicated procedure like TGA, DORF, or Fontan. But the rest, those 4 procedures, please teach to all these specialists to be able to do it at these 34 provinces. 34 provinces. And as a gift, I said, because the $4 billion US money that I have, when we buy 350 cath labs, we get a very deep discount. Then we realized that the budget we have excess fund. I promised to the team, I will use this budget to buy maybe 10, 14 Da Vinci Series 5, the latest in the world, to do robotic surgery that we can distribute. So all these thoracic surgeons not only do it manually, my apology to Pak Puruhito and Pak Paul that you are an expert to do manual, but let's do TCAP, let's do bypass without cutting, the bone of the chest. Because we can do then robotic surgery. I have enough money to do it. Maybe 10, minimum 10 I can buy and distribute to several hospitals. So there is a new toys for this surgeon, Surgeon like my kids like, "Pa, there is a new PS2, I want to buy PS3. There is a PS4, I want to buy new PS4. There's a PS5. The cardiac surgeon is the same thing. Why in Malaysia they have, Da Vinci? Now Da Vinci Series 5. Why in US and Japan they have Da Vinci Series 5? Indonesia we only have, Siloam only get Da Vinci Series 4. Okay, let's buy Da Vinci Series 5 because we have the money. But of course, you need to help me to get these 34 provinces to do surgery, open heart surgery, including pediatric, those 4 procedures. Yeah? VSD, ASD, PDA, and TOF. And for you that feel that, hey, Pak, it's not only, BTKV is not only about cardiac, it's also thoracic. I just learned what is the difference between thoracic and cardiac. There is one doctor that come to me and said, "Pa, I'm working for you. I'm a thoracic surgeon. Yeah, please remember that #1 killer in cancer is lung cancer." I remember that. Lung cancer. And Pa, in cancer is more complicated than heart in my view, because the treatment is not only one treatment. Heart, you need a knife, But in cancer, sometimes you use chemotherapy, sometimes you use radiotherapy, sometimes you use surgery, sometimes you use immunotherapy, whatever therapy it is, But what he told me, Pa, as you know, lung cancer is the killer #1. And the first treatment of lung cancer, I just realized it this morning, is surgery. If you have stage 1 cancer, it's not chemotherapy, it's not radiotherapy or immunotherapy. The surgeon has to come in. But we need to do better screening, which is, I agree. Cancer, as an ex-banker and engineer, cancer strategy is not the treatment. Cancer strategy is do better screening. Because if you identify cancer early, that will reduce the cost and will improve the quality of living and chance of living. With the current technology, if you identify cancer in the early stage, then you can definitely have a bigger chance to improve in terms of therapeutics. So that's why if you move back one slide, or two slides, move back 2 slides. So it's not only this. What we are doing in cancer is, we are now deploying 514 CT scan across 514 cities. So these 514 cities can do low-dose CT scan to identify potential lung cancer earlier. And on top of this CT scan in 514 cities, we also will distribute 514 immunohistochemistry lab in the cities. At the provinces, we will have a next generation sequencing pathology anatomy labs. But at the 514 cities, with the money that we have, we will deploy the immunohistochemistry. So this CT scan, to do low-dose CT scan, and also the immunohistochemistry labs, hopefully can improve the quality of screening of lung cancer. What I didn't realize, I need the surgeon. So the next phase part, we only have BTKV, the thoracic surgeon prepared for 34 provinces. But the lung cancer, the CT scan, and the immunohistochemistry lab are available at 514 cities. It's now up to you. How do you like to do referral or mix and match and do the calculation whether we need to push the thoracic surgeon down to the cities, or you want to keep it at the 34 provinces and do referral, But then we have to consider several things. But for you that working in thoracic, don't worry, because you will receive flood of patients, because our screening will be improved drastically in the next 2 or 3 years, because all 513 cities will have CT scan that can do low-dose CT scan, and we will have also a immunohistochemistry lab at those 514 cities. So that is what the government is doing. But at the end of the day, whatever infrastructure that we have cannot be used if we don't have the people, and we don't reform our BPJS payment methodology. So that's what we are doing now. We are changing the grouping of our DRG from INA CBGs to Indonesian DRG. INA CBGs is inherited from Malaysia. So we are copying the Malaysia because at that time Indonesia don't have a disease risk group. So in the last 2 years, I realized that this is a key to provide the healthcare facility. It's not only the facility, the infrastructure, but you need also the source of funding so the doctors are properly incentivized to do this. And I would like to prioritize on the disease that kills people. Like heart disease will have more priorities in terms of payment than, and I'm sorry to say, like cataract operations in eyes. Why? Because cataract, at least you don't die, but heart disease, you will die. So that's why my apology to many doctors. All of us have a limited resources. So we need to distribute resources based on priority. The priority is given to this one. And this risk group is already finalized. Hopefully the government will issue as quickly as possible the new risk group. And this is the person are sitting there, the person responsible. Pak Irsan, why don't you stand? Why don't you stand? So if you want to lobby on how much money that you have to reimburse for every treatment, he is the guy. And the HBTKV is very smart to understand, to bring that person in this room. Yeah, because he is the one that will determine this. Okay, I do hope at the end of the day, thank you for the guest that is coming to Indonesia. I believe, I still remember when I went to Davos one day and met with one of the African leaders. I didn't remember his name, but he's the president of South Africa. He mentioned that in South Africa there is a saying, yeah, if you want to go fast, you go alone. But if you want to go far, then you have to go together. So that's why if you want to save life, many people's life because of heart disease, you need to go together with other people. Yeah? You need to go together with people from China, from India, from Egypt, from Japan, you know. Universitas Erlangga need to go together with Universitas Indonesia, you know, that will be together. Universitas Udayana and the rest, you know, because that will be the critical ingredients for us to go very, very far. I would like to close with a pantun juga, with a pantun juga. Pagi-pagi kita masukkan sepatu dan pasang tali. Siap-siap untuk pergi ke kafe. Ya. Pagi ini pergi ke Bali untuk menghadiri PIT ke-16 HBTKV. Terima kasih. Thank you.
Wonderful pantun. Pak Budi Gunadi Sadikin mohon tetap berkenan di atas panggung because we would like to officially open this event by striking the gong.
And for that, I would like to invite to join on the stage to accompany Minister of Health to open this ceremony, to open this event. Dirjen Keslan, Mr. Azhar Jaya, please come to the stage. Ketua Kolegium BTKV, Mr. Putuyasa, Ketua HBTKVI, Dr. Prasetyo Edi, dan Ketua Panitia Dr. Rian.
Dan juga kami mengundang Dr. Budi Rahmat untuk dapat berkenan naik ke atas panggung untuk bisa mendampingi prosesi pemukulan gong. Ya,
We
kita akan
will give you the countdown in 3, 2, 1. Congratulations!
and the 5th annual meetings of Asian Association for Pediatric Congenital Heart Surgery and 16th annual Scientific of PIT HBTKVI is officially open.
Congratulations!
And give a big applause.
To all of VIPs, please stand here. Please stand here. Make a line here. Excuse me. To all of VIPs, please make a line here.
Nah, kami akan ada 2 sesi untuk fotografi.
Okay. And is everyone ready? I will give you countdown in 3, 2, 1. Okay, one more time. In 3, 2, 1. Okay, one last time. Everyone, please stand up. And we'll take a picture. Salam sehat. Tangan di dada. Oh. Jantung, jantung. Jantung sehat, mohon izin. Thank you so much.
Terima kasih banyak pada seluruh Bapak Ibu hadirin. This concludes the opening ceremony of the 5th AAPCHS and the 16th Annual Scientific Meeting of HBTKVI 2025. On behalf of the committee, we extend our deepest gratitude to all distinguished guests and participants. After the session, we will break for Friday prayers and also lunch.
Demikianlah seluruh rangkaian acara kita pada hari ini, dan mewakili panitia kami mengucapkan terima kasih yang sebesar-besarnya kepada seluruh tamu kehormatan dan peserta yang hadir. Selamat menikmati hidangan santap siang dan juga melanjutkan dengan sesi Friday prayer. Terima kasih atas salat Jumat, terima kasih.
And after this session, we will break for Friday prayers, Nana, and also lunch. And the program will resume at 1:30 p.m. sharp with the scientific sessions.
Baik, dan setelah sesi ini hadirin sekalian, acara akan dilanjutkan dengan istirahat, sholat Jumat dan makan siang. Program selanjutnya akan dimulai kembali tepat pukul 13.30 dengan sesi ilmiah. Terima kasih, sampai jumpa.
Kami mengundang kepada seluruh BTKV untuk dapat bergerak ke depan untuk dapat berfoto bersama di depan panggung. Sekali lagi kami mengundang kepada seluruh BTKV untuk dapat hadir ke depan panggung untuk dapat melakukan sesi foto bersama.
you.